So, diabetes and pregnancy, what do you need to know? And I'm very passionate about diabetes and pregnancy because I think it's a really important area. And it's also an area where just a few small changes can go a long way in the care that we give women and really have a significant effect on the adverse outcomes of pregnancy. These are my disclosures. So the things that we're going to talk about today are the adverse outcomes in diabetes pregnancies. We're going to think about what you need to know about in preconception care. And we're also going to have a look at how well we're doing with the National Pregnancy in Diabetes Audit and just explore a little bit the barriers to preconception care. And finally, I'll finish on what tools you can use to help you in your management of women with diabetes. So there are around 700,000 births in England and Wales, and around 5% of these women will have diabetes. But out of those women, we're just focusing really on those with type 1 and type 2 diabetes, which is a much smaller proportion than those women who develop diabetes in pregnancy. So what are the risks? Because they are significant. And you can divide those up into early risks and late risks. Certainly for women in the first trimester, miscarriage is a much higher risk. But what we really worry about are the congenital anomalies for babies, and that includes neural tube defects, which are also increased in women with diabetes. And it's particularly cardiac defects, so we're talking about VSDs, coarctation, transposition, or gastrointestinal anomalies, and renal ones as well. But it's probably cardiac ones that we see the most. And it's all glucose-fueled teratogenesis. So when you look at the HbA1c on the left-hand side in the first trimester, you can see the number of congenital malformations and the relative risk on the right-hand side. And essentially, if your HbA1c is around 7 to 9%, your risk is around 3 to 4-fold higher for congenital anomalies. But that risk for the increased congenital anomalies rises as your HbA1c goes up. So you can see that if your HbA1c is around 12%, that risk is 12-fold higher, which is significant. And it's a very difficult conversation to have with women when they present with levels like that. But the key is to get the HbA1c right early on. And that's because of some of the embryology, which certainly was a long time ago for me. But if you look on the right-hand side, this is showing you the development of the heart. And on the right-hand side, you can see that by 35 days, the structure of the heart is already developed. And by 8 weeks, all the chambers are partitioned. Many women are only being referred to antenatal services at that time. And that's why it's so important to get the HbA1c right preconception so that it's right early on in the first trimester. For women, the other early risk is hypoglycemia, and that's probably more so for the women with type 1 diabetes. It's a high risk if you've got previous impaired awareness of hypoglycemia. It's also high risk if you've got a history of severe hypoglycemia. So if you've had a hypo where you needed third-party assistance, you're more likely to have problems in that first trimester. And up to around 45% of women with type 1 diabetes experience severe hypoglycemia in that first trimester. And it's hugely frightening for the women and for their families, and the consequences are significant. So we see head injuries, seizures, and death is one of the other consequences. In terms of the later risks, we're worried about fetal macrosomia, the baby's getting too big, but we also see intrauterine growth retardation, so that's problems with the placenta affecting the growth of the baby. Increased risk for preterm labour, shoulder dystocia, if the baby's too big, the head comes through, but the shoulders get stuck, and that's very traumatic for everyone involved. We see more neonatal hypoglycemia, so the baby's producing far more insulin to the maternal glucose levels, but can't switch that off after delivery. So it just takes a little bit of time, and we have to just check that and treat it as necessary. We see more respiratory distress, so those babies are more likely to go to the neonatal unit. But the issue that we worry about really is stillbirth, and that's still high, about 25 in 1,000 births. But we deliver babies much earlier for women with type 1 and type 2 diabetes to try and to try and prevent that happening. And I think for women in our unit, it's about 37 weeks is the average time that we deliver their babies. For mothers, there's also an increased risk for preeclampsia and acceleration of their diabetes complications, particularly the eyes and the kidneys. So all those growth factors that are helping the baby grow aren't really good for your eyes or kidneys, and we have to monitor that very closely through pregnancy. And those women who have nephropathy are really high risk for problematic issues in pregnancy, and we've seen women who've developed loss of vision in the third trimester, which is also very worrying. So what do you need to think about before pregnancy to get this right and reduce those risks? The key is preparation. And so for all women with pre-existing diabetes, we say they should be on high-dose folic acid 3 months before conceiving to reduce the risk for those neural tube defects. They need to stop ACE inhibitors and ARBs and statins. Certainly ACE inhibitors associated with renal teratogenic effect. Statins, I think it's a little bit unclear, but certainly the fetus needs cholesterol to develop, and potentially statins may be harmful. So again, we would stop those a couple of months before pregnancy. The women who just need it for hypertension, I think you can stop them well in advance and convert to other older antihypertensives such as methyl-dopa, labetalol, nifedipine. For women who are taking them for nephropathy, there may be a bit of a decision to make, and you might continue those medications, at least the ACE inhibitors and ARBs, until they conceive and then stop them. It's important to ensure all women are up to date with retinal screening. And for any women with hypothyroidism, you want their TSH to be less than 2.5 to reduce the risk of neurodevelopment issues in pregnancy. When it comes to glycemic control, we're aiming for an HbA1c as close to 6.5% or 48 millimoles, or even lower if possible, but the key is to do that without hypoglycemia. For women with type 2 diabetes, we want to stop all medications except metformin or insulin. If they're on diet control or they are just on metformin, you might not think that they need to do any blood glucose monitoring, and they might not need to in that preconception period, but it's good if they have a blood glucose meter, because then they can start doing it as soon as they get pregnant. For the women with type 1 diabetes, it's a little bit more complicated, and I think unfortunately we've alienated a number of people from our services, and we're trying to work on those issues to try and keep more people engaged. But it's important that we see them. So if you are seeing them and they're not having any diabetes team support, it would be great if you could try and refer them on and encourage them to come back to see us. We need to think about carbohydrate counting. We might transfer them onto insulin pump therapy. Of course, now we all have Freestyle Libras, which is really helping these women. Continuous glucose monitoring systems will be available for pregnant women from next April, but they might need psychological care as well. These women are going to be testing 8 to 10 times a day to try and get this right. So your support with blood glucose strips is essential, but of course that might be lower once they start using a Libra. These women are also at risk, just like the people who take SGLT2 inhibitors, they're at risk of euglycemic ketoacidosis. So a blood keto meter for these women is essential with strips so that they can test for ketones in pregnancy at much lower levels than we would usually advise. So it all sounds quite straightforward so far. How well are we doing? And the National Pregnancy and Diabetes Audit has been running now for about 5 years. It's voluntary, so not everybody is putting their data in there, but certainly a lot of units are. So this slide is showing you how many women achieved the first trimester HbA1c of less than 48 millimoles or 6.5%. The blue bars are women with type 1 diabetes, and the grey bars are women with type 2 diabetes. And you can see that we're really not doing a great job. It's somewhere less than 40% with women with type 2 and less than 20% for women with type 1 diabetes. And disappointingly, this isn't changing. This has been the same for the last 5 years, despite all the input that we're trying to put into people and women with diabetes. It's not surprising. The women who have higher HbA1cs are more likely to be from deprived areas. They're more likely to be younger with type 1 diabetes, For type 2 diabetes, women from Black and Asian backgrounds are less likely to get into target. And of course, high levels of deprivation also mean you're less likely to get there as well. So I don't think that's rocket science, but we're not getting to the women who really need our care, those vulnerable ones. The story is a little different for folic acid. The situation is reversed. For type 1 diabetes, in the blue bar, you can see that just over 40% of women are on 5 milligrams of folic acid a day prior to conceiving. And for type 2 diabetes, it's half of that. It's just over 20%. So there's really a lot of work that we need to do, and I think it's important that primary care and secondary care, we work together to try and change this. So what are the barriers? Why aren't we getting anywhere with this? I was reminded of a woman that we saw in January this year. She's 44 years old, type 2 diabetes for 5 years, and she was on prescribed metformin 1 gram twice a day. She was seen in September in the practice. She was travelling to look after 6 parents abroad. She was very stressed. She wasn't really taking her medication, and her HbA1c was 13% or 120 millimoles. BMI was 49. So there was a discussion about weight, about going to some lifestyle changes, and the plan was for her to restart her medication and recheck in 3 months. When she came back to the practice in January, she was 6 weeks pregnant. She was referred to the antenatal clinic and she started some blood glucose monitoring, but her blood glucose levels were 13 to 17 millimoles. She was started on insulin, Humulin I, Novorapid with meals, but she miscarried at 12 weeks. And I was just thinking, why didn't the preconception counselling occur in this? And it's not surprising. You have to talk to her about stress, maybe depression, maybe she needs to be referred to IAT. Weight is clearly a problem for her, so that's something else to discuss. You might talk about exercise prescriptions to improve her weight. You might even think about bariatric surgery. That's probably going to be the thing that she needs. Her ACR was elevated, so you've got a discussion about complications. And then finally, at that point, you're going to talk about her HbA1c and the medication changes. Given her HbA1c, how long she's had diabetes, I think it's unlikely that metformin alone is going to work. And so you need to have a conversation about the next step in medication. And finally, then you might get to pregnancy, and you're meant to do that in 5 to 10 minutes. I think that's pretty much impossible. So it's really not surprising that we're not having these conversations with women. This is taken from a qualitative study where they interviewed women with type 2 diabetes, and they came up with some other thoughts which I think are interesting and help you think about how we need to change preconception care. They talked to healthcare professionals involved with women with type 2 diabetes and women who'd been through pregnancies themselves. And one of the issues that they mentioned was the lack of visibility of pre-pregnancy care in routine type 2 diabetes. It's not featured in initial education, so that's Desmond or conversation maps, and it's rarely raised in routine care, so women don't know about it, they don't think it's an issue. And for healthcare professionals, there are no electronic prompts. We've got a lot of templates for other things in diabetes, but not preconception care. There's also something about the perception of type 2 diabetes. For women, they felt that there was a lot of stigma. They felt that their diabetes was self-induced and therefore they shouldn't really be talking about anything else. They felt judged about this. And because of all these feelings, they were less likely to disclose their reproductive intentions. For healthcare professionals, we used more labels which were negative. We said things like non-compliant, less important than type 2. But of course, the risks are just the same for type 2 as they are for type 1 diabetes, so that's not true. I think language in diabetes care is really important, and if that's something you want to know more about, there is an NHS England Language Matters document, which is just quite a simple approach, but just highlights some of the language that we use when talking to our patients and when talking about our patients, which probably doesn't help them. There's also the communication is on other issues. It's not on reproductive issues. It's often focused on weight or other things, and because it's not in the context of pregnancy, it's less meaningful to the women. Reproductive intentions, that's quite difficult. I think the desire to become pregnant is very high for women. And once they make that decision, that's what they want to go and do. And certainly our preconception nurse calls her clinic an antenatal clinic. More women are there pregnant at their first and second visit than they are on contraception. The awareness of pre-pregnancy care guidance, I think there's limited awareness, partly because it was felt it was not needed. And I think we saw Professor Lean's slide earlier about type 2 diabetes being mild diabetes. It's clearly not the case now, and we're also seeing a lot of children and young adults with type 2 diabetes. I think there are around 7,000 young adults and children with type 2 diabetes, and they have an aggressive form of diabetes, often get complications early, and many of them are going to be going through pregnancy. Accessing pre-pregnancy care, it's difficult, it's ad hoc, there's no systemic identification of women with type 2, and I think the pathways are just not very clear. So what can you use to help you day to day when you're seeing women with diabetes? There are EMIS templates that are designed for this. I don't know how easy it is for you to see, but certainly they take you through contraception, pre-contraception advice, pregnancy advice. They talk about folic acid and help to remind you about some of those things that you need to talk about. These aren't routine, unfortunately. They're not in all diabetes templates, but certainly if you can liaise with your local CCGs, they might be able to change that. Every contact counts is the other sort of phrase that you should have in your mind. I think it's about having this conversation with every woman that you see with diabetes. So it doesn't matter what you're seeing them for, whether it's a practice nurse visit, whether it's the medication discussion visit, every contact counts. So hopefully they keep hearing it from everyone that they see. And how might you do that? So certainly when we met for a Pan London meeting for people working in pregnancy from both primary care and secondary care, we talked about the conversation that you have. And I think sometimes it's about, what are your plans for pregnancy? And I'm certainly guilty of asking that question quite regularly. And it's often a yes or no answer, but it's not as simple as that. So you can say, what are your thoughts on having a baby in the next couple of years? Because then it just helps to broaden out the discussion a little bit. You can go on to ask them, do they know why we discuss diabetes and pregnancy? And you can also talk about the increased risk of adverse pregnancy outcomes. But the important message is that with correct medications, with good blood glucose levels, high dose of folic acid prior to pregnancy, you can reduce those risks significantly. And you can signpost them to further information. And then it depends. If they're a little bit unsure, you can talk about how they're planning or preventing a pregnancy. If they're thinking, yes, possibly, then refer on to services. And certainly I know that in Camden, we've got one of our diabetes nurses is doing doing preconception clinics. But if it's no, then it's all about contraception. But just advise them to come back and talk to you again when they're thinking about it. There are also information prescriptions. I don't know how many of you use them, but they're from Diabetes UK. They're available for glycemic control, for lipids, blood pressure, and there's also one on diabetes, contraception and pregnancy, and I think that's quite helpful. NHS, the NHS website has some good information. And Diabetes UK, it's always a good source of validated information, medical information for people with diabetes. Queen's University in Belfast have also got quite a nice video and lots of different discussions there, so women can go away and have a look at that as well. So I'll end there, but just the 3 take-home messages. Preconception care is essential. It can reduce the significant risks associated with pre-existing diabetes and pregnancy. Every contact counts. Talk about diabetes and pregnancy for all women of a childbearing age. And focus, if they are interested in pregnancy, focus on glycemic control, high-dose folic acid, because those two things can really make a big difference to the women that we're seeing. And hopefully refer on to a preconception team if you have them. And certainly, speaking for our team, we're more than happy to have a one-off conversation with women to discuss all these different issues, and then they can continue under your care. Well, there, thank you.